All right. So, as we continue on our journey on airway management, I want to talk about the roadmap from A to success. How you get to a successful airway. Now, again, remember that emergency airway management is all about, first and foremost, oxygenating the patient. Second, minimizing the risk of aspiration. And finally, helping them get rid of excess carbon dioxide. And it's critical to remember that your goals are in that order. Oxygenation is the most important thing that you're trying to achieve. Now, as you're working your way from the heights of your airway management, and you're trying to reach the end of your quest, sometimes you find that you have to stop and make some corrections. How do we know that we're doing the right things? We start with checklists. Now, checklists are tools for experts. They are not instruction manuals. If you are trying to do rapid sequence intubation from a checklist, you shouldn't be in the room. They're prompts to help you not miss key actions, mostly in preparation. Checklists should be very fast, and many can be completed, at least in part, in advance. So any of you who has ever checked an airway bag, make sure that all the equipment that's supposed to be there, you're doing part of a checklist in advance. And any part that you can do in advance, you should. So in the moment, you task load yourself as little as possible. So here is an example of the kinds of things that would be on an airway management checklist. First, the equipment. Well, if you have everything safety sealed in a bag and you've made sure all of those items are there, then you've already got them. You don't need any more. If you know that you have all of your meds, including your post-intubation meds, which are often forgotten, in a single drug box, pouch, whatever, and it's safety sealed, then you've done that part of the checklist. Now the plan, always good to review. Who's doing what? What do we do if the airway attempt fails on the first try, second try? And what do we do for hypotension? And then the patient, of course, you have to do in the moment. And that's where having that checklist just to make sure everything's done is very helpful. Because by having that checklist, making sure that you have everything you need, when it's time for you to move through an airway correction, you've got the supplies on hand. So we want to make the first attempt count. Johnson County MedAct in Kansas City years ago did an intervention to improve airway management. Now, before the intervention, they had about a 70% first attempt intubation rate. After the intervention, which included both education and on-scene coaching, they got themselves up to a 98% first attempt intubation rate. Now, this is very old North Carolina data, but paramedics in one large county had about an 85% success rate on their first attempt. However, if they missed the first attempt, there were multiple additional attempts with an average of 2.2 attempts per airway. Now, knowing that 85% were the one attempt, it means there were a lot of 3 and 4 and 5 attempt airways out there. For what were called the MTIs at the time, who had much less experience, was less than 1 and 2 first attempt success, and the average was 9 attempts, which means that if half of them happened on the first attempt, many of them were happening on the 12th, 15th, 20th attempt. So you want to make your first attempt count. You want to make sure your checklists are completed, you have optimal head and neck positioning, you're using a bougie every time, your equipment is ready, and your team is ready. What happens if it doesn't work the first time? Well, you're in an emergent airway setting. This isn't an OR. You can't defer the airway management and reschedule the case. You can probably defer the intubation. In the U.S., we have an obsession with putting a tube through the cords. Some other countries recognize that other non-endotracheal airway management that's invasive is just fine. The blind insertion airway devices, the supraglottic devices, that you can ventilate patients for a week or more on those. But in the U.S., we really push for intubation. So we have to keep in mind that sometimes that's not going to happen. And again, our goals are oxygenate the patient, minimize the risk of aspiration, get rid of excess carbon dioxide. And if you can do it with another tool, you have successfully managed the airway. So you want to have a plan for what to do next. So that's a clearly defined decision support tool that you've practiced with, that you could regurgitate in your sleep, and that you actually use when things go bad, which means it can't be too complex. This is a typical airway algorithm from a set of EMS protocols. And if you were looking at it for the first time, you'd say, my Lord, there's a lot of stuff on that. But once you've gone through it, once you've practiced with it, it's straightforward, it's easy to use, and it flows naturally. And by practicing with it and being able to regurgitate it, you feel comfortable with that technique. Here is another approach called the Vortex airway approach, and this comes out of the operating room. The idea is that your patient's airway status and oxygenation status is on the top of a funnel. So the green, their oxygen levels are good, everyone is happy. When they are no longer in the green, when they are starting to get hypoxic, they are falling down the vortex, they're going down that funnel. You have 3 different techniques you can use to try to get them oxygenated again. Face mask ventilation, supraglottic airways, and endotracheal tubes. And with each of those, you get up to 3 attempts. Now that's a maximum. You don't have to do 3 attempts. But if you cannot get your patient oxygenated after at most 3 attempts of face mask ventilation, supraglottic airway placement, and endotracheal intubation, you mandatorily move to an emergency surgical airway. And by implementing this approach, instead of people just spinning round and round and round and moving from non-surgical airway attempt to non-surgical airway attempt to non-surgical airway attempt, all while the patient is hypoxic, by instead doing this and saying, you got up to 9 attempts, 3 techniques, if you don't get it, you're doing the emergency airway. This approach essentially eliminates hypoxic injuries and deaths to patients during airway management misadventures. Any questions? Please email me. Thanks so much.